I'm Eddy, an ENT surgeon. Today, I would like to talk about vaccine, but not the COVID-19 one. Let us explore more about another valuable prophylactic vaccine. As you know, not all the virus will kill the host cell after the infection. They indeed cause the persistent infection and eventually result in cancer. They are also known as oncovirus. These viruses account for an estimated 12 to 20% of the human cancer worldwide. The most common ones you should be familiar with are HPV, the hepatitis B and C virus, and Epstein-Barr virus. For the other four, which are relatively less common. The use of the vaccines to prevent certain human cancer are now feasible, but only the prophylactic HPV and Hpv virus vaccines are available. Vaccines nowadays is a very hot topic, but how much do you know about the Hpv vaccine? As you know that there are many different kinds of mechanisms in producing vaccine. All of you should hear about the mRNA technology because of the current COVID-19 vaccine. However, the one with a higher safety profile is actually used in producing the vaccine against these oncoviruses, namely the HPV and the Hpv vaccine. The Hpv vaccine is using the recombinant DNA technology to produce the viral-like particles of the major papillomavirus L1 protein from the yeast cell, which is highly immunogenic. However, as it does not have any viral DNA or RNA genome, they are non-infectious and non-oncogenic. This prophylactic vaccine has been launched in the market for about 15 years already. The first one, for Merck, only protects against 4 HPV serotypes. The latest one, the Gardasil 9, is against 5 additional strains. Nevertheless, they all cover the high-risk serotype, the HPV 16 and 18, which are responsible for the majority of the cervical cancer and the head and neck cancer worldwide. As this vaccine has been there for more than a decade, its safety and efficacy are well shown in various large-scale clinical trials and post-marketing surveillance. In one of the recent large-scale nationalized study conducted in UK, including the girl and a young woman aged 10 to 30 years old, who has been vaccinated through the routine vaccination program, they showed that the HPV vaccine was actually associated with a substantial reduction in the risk of invasive cervical cancer, as well as the CIN3 in the young women. Such result is even more remarkable if they get vaccinated at an earlier age. Given that the heavy burdens of the HPV-related disease to our healthcare system, as well as the promising results in the safety and efficacy of the vaccine, WHO recommends that the girl aged between 9 and 14 years, when most of them have not started the sexual activity, should get vaccinated. As females has 10 times risk of suffering from the HPV-related cancer than male. Therefore, the WHO states that such strategy is the most effective public health measure against the cervical cancer. However, WHO did not have a particular recommendation for the male vaccination, as they believe that the heterosexual male will be protected because of the herd immunity caused by the high female vaccine coverage. But have you appreciated that the change of the disease pattern caused by the HPV in the past decade? Nowadays, the OP cancer is the most common cancer caused by the HPV rather than the cervical cancer in US. Almost 70% of the oropharyngeal cancer are due to HPV, and the male patients are generally 5 times more than female patients. In addition, this prophylactic vaccination against HPV are highly effective in the prevention of the condyloma accumulata, as well as the anal intraepithelial neoplasia. Therefore, it should be the time for us to seriously think about adopting the gender-neutral HPV vaccination. It will become a trend worldwide in the near future. In line with the coming trend, the FDA granted an accelerated approval for the request to add the oropharyngeal cancer and the head and neck cancer prevention as one of the indications of using the HPV vaccination in June last year. At the same time, the current advisory committee on the immunization practice from the CDC recommend that both male and female aged 11 to 12 years should get vaccination. In the United Kingdom, the routine vaccination program for girls aged 12 to 13 has been introduced for more than 13 years. This program was extended to boys about 2 years ago. Currently, many countries have included the HPV vaccination in their national immunization program. Furthermore, 57 countries even adopt a gender-neutral vaccination program, including many major developed countries, such as Australia, Canada, Germany, United Kingdom, and the United States. How about the situation in Hong Kong? This vaccine was approved in 2008, and the routine vaccination for the primary 5 and the 6 female students was just started 2 years ago. Before that introduction, the vaccine uptake rate was actually quite low, below the single digit according to a local research group. However, at the end of 2020, according to the reply from the Secretary for the Food and Health in the Legislative Council, 24,200 primary 5 female students from about 600 primary schools have received their first dose of the HPV vaccine. The uptake rate is about 85%. Although this figure is still far below the average immunization coverage rate of the primary school student under the Hong Kong Childhood Immunization Program, it is already a dramatic increment from the past. For a vaccination program to be succeed, there are 2 important components. First, the acceptability of the vaccine is utmost important. The uncertainty, the negative attitude definitely have a direct impact on the uptake rate of the vaccine. Secondly, the high coverage rate is the prerequisite for the successful immunization program carried out in the community. Understanding the target population's willingness to have vaccination will identify the important barrier and the concern of your target group, so that the corresponding plan can be carried out to contribute to the success of your program. According to the data from the European Center for the Disease Prevention and Control of the Disease, there are several barriers identified. Obviously, the people are reluctant to get the vaccine due to the lack of the knowledge and the awareness of that vaccine and the related disease. Secondly, the wrong perception of the efficacy and the side effects of the vaccine will obviously reduce their temptation. Furthermore, the fear of the increasing the promiscuity and the risky sexual behavior after the vaccination will stop the parents from vaccinating their children. Last but not least, the cost is still the major concern, especially in many underdeveloped African countries. One of these large-scale population-based studies exploring the factor affecting the decision-making in the parents for the vaccination in UK showed that only half of them are aware of the routine vaccination program for the girl, but only 23% knew that boys are also included. About 60% reveals that they are going to vaccinate their children, but 10% actually declined that offer. After further analysis, the parents of the girl are more willing to vaccinate their child than those of boy. Furthermore, with the positive attitude towards the vaccine and a high HPV and vaccine awareness are some important factors of getting vaccination. In contrast, previous vaccine refusal for a child is the strongest predictor of not wanting to get the HPV vaccine. These findings are in line with the global data, which consistently show that the uptake rate in boys are actually lower than girls. How about our locality? The HPV Prevention Alliance and my research group has conducted a cross-sectional study this year on the parental attitude towards the HPV vaccination for the children. That structured online surveys include more than 900 parents of the primary 5 and 6 students. The finding again suggests that the parents of the girl are more likely to accept the vaccination than those of boy. In addition, for those who accept all kinds of the routine prophylactic vaccine and know about that newly implemented routine HPV vaccination for girls are important factor to predict the parental acceptance of getting vaccination, provided that they actually come from a similar age group, family income, and also the education level. Our surveys show that the uptake rate for boys was about 40%, even though they know that boy is eligible for the HPV vaccination. So what are the features of that group of parents? Results show that they are actually from lower education level with a lower family income, and they generally believe that their children will start dating and sexual behavior early in age, and they think that the appropriate age for the HPV vaccination should be lower. With the extension of that free routine vaccination program to boy, about 40% more parents will agree to vaccinate their boy. It implies that the cost of the vaccination is likely to be one of their concerns in their decision making. So in conclusion, what should we do in order to raise the HPV vaccine uptake rates in our locality, especially for boys? I think organizing more education campaign and talk will be very important, so that we can let them have a correct knowledge about the vaccine and also raise their awareness towards the susceptibility of that infection, especially for boys, and also the problem of the HPV-related disease. And again, also emphasizing the benefits of getting vaccinated and correcting the misconception on the side effect will be obviously beneficial. Extending the current program to boys will definitely raise the uptake rate among boys. Being a healthcare provider, we should deliver correct information about the vaccine and the problems of the HPV-related disease. It could be very important in supporting some undecided parents to make the decision to vaccinate their children, and also we can contribute to the elimination of the HPV-related cancer in the world in the near future. So after this talk, have I changed your attitude towards the HPV vaccine? Would you vaccinate your children? So lastly, I have to thank the HPV Prevention Alliance to organize this valuable local surveillance on the HPV vaccination, and also Professor Paul Chen and Professor Martin Wong from the CUHK for their assistance in this surveyed analysis. Thank you for your attention.